Hi, everyone. My name is Vlad Lakhter, and today I will go over the topic of percutaneous left and right ventricular support hemodynamic devices. I don't have any relevant disclosures. The learning objectives for this talk include a brief overview of cardiogenic shock, which will create the basis for discussion of the various available percutaneous hemodynamic support devices. We'll also talk about the pressure volume loops, which I think are an important topic to get a more in-depth understanding of the specific hemodynamic effects that we can expect from any given percutaneous support device. And finally, we will review the options for percutaneous left and right ventricular support devices. And as a fair warning, pictures of my twins will be presented intermittently throughout the talk. Historically, cardiogenic shock has been shown to complicate approximately 5 to 10% of all cases of patients presenting with acute myocardial infarction. This can be seen in this 30-year-old trend. The overall incidence has had minimal variation over that time period. Cardiogenic shock is defined by both hemodynamic and clinical parameters. The hemodynamic parameters include low systolic blood pressures, which are usually under 90 millimeters of mercury, cardiac index of less than 1.8 without support or less than 2 with support. And usually patients will have an increased left ventricular and diastolic pressure of more than 18 millimeters of mercury. In addition to these objective parameters of blood pressure, cardiac index, however, patients with cardiogenic shock should also have clinical signs of hyperperfusion, which include cool skin, decreased urine output, or alteration in their mental status. Historically, the in-hospital mortality for patients who present with acute myocardial infarction and cardiogenic shock has been close to 80%. And as you can see that in the 1990s, there was a decline in mortality, which was likely precipitated by the introduction of primary angioplasty into the armamentarium used to treat patients with cardiogenic shock. Unfortunately, despite the significant progress that was made initially in the 90s, the contemporary trends of in-hospital mortality associated with cardiogenic shock have remained around 40 to 50%. One of the first things that are commonly done for patients that are critically ill is the initiation of catecholamines and inotropes. These agents serve to acutely improve systemic hemodynamic parameters and provide time for further interventions to be implemented as these patients are at risk of imminent death. However, despite initial hemodynamic improvements, these agents generally serve to increase the total myocardial oxygen consumption, and as a result do not generally by themselves reduce the in-hospital mortality. Nevertheless, given the severity of the illness and the poor outcomes of these patients, current ACC/AHA guidelines do recommend individualizing these agents for particular patients. So what can we do about this persistently high mortality in cardiogenic shock patients? As I alluded to earlier, there was a significant reduction in the in-hospital mortality seen in the decade following the introduction of coronary angioplasty and stenting into the clinical practice. However, in the early 90s, there was still equipoise as to the role of early primary angioplasty in the setting of cardiogenic shock. The reason for that was that the initial data evaluating the use of primary angioplasty came from small studies which did not by themselves have the power to detect any significant differences in mortality. For example, a small randomized trial that randomized 55 patients with cardiogenic shock to invasive therapy versus conservative therapy failed to detect a significant difference in 30-day mortality between the two groups. The 30-day mortality, however, was very high in each of the two treated groups. It was for this reason that a randomized control trial was necessary to definitively answer the question regarding the role of earlier vascularization in the setting of cardiogenic shock complicating acute MI. And the shock trial, which was published in 1999 in New England Journal of Medicine, answered that question. The trial included patients who presented with acute coronary syndrome and had evidence of cardiogenic shock. And in this trial, shock was defined as systolic blood pressure under 90 millimeters of mercury for at least 30 minutes, as well as evidence of end organ hyperperfusion. The onset of shock had to be within 36 hours of initial infarct. After screening approximately 1,500 patients, 302 patients were ultimately randomized, and about 150 patients in each arm were randomized to either revascularization or medical therapy. And to note, patients in the medical therapy arm, there was a minimum of 54-hour delay that was recommended prior to crossing over into the revascularization arm. The primary endpoint of this trial was 30-day all-cause mortality. Despite the numerical difference seen in this graph, there was actually no statistically significant difference in 30-day mortality. However, at 6 months, there was a clear superiority and a statistically significant reduction in the mortality of patients that underwent revascularization compared to those that were treated conservatively initially. And I'm sorry, the number here should be 50.3 versus 63.1%. In fact, the early revascularization currently receives a class 1 indication for that reason for all patients with acute coronary syndrome who present with cardiogenic shock. But the question remains, is there anything else that we could do beyond early revascularization therapy to support patients with cardiogenic shock? And of course, that's where the percutaneous mechanical support devices come into play. So the most commonly used left ventricular support devices are illustrated here. And for the purposes of this talk, we will focus on intra-aortic balloon pump, Impella, and VA ECMO. Before we go any further, it's important for us to briefly review the concept of a pressure volume tracing. PV loop will help us explore and really understand the differences in the hemodynamic effects between the various left ventricular support devices. The PV loop fundamentally describes the hemodynamic relationship within the left ventricle between the interventricular volume and interventricular pressure. PV loop is the major determinant of myocardial oxygen demand, and therefore changes in PV loop geometry can have significant hemodynamic effects. As can be seen in this figure, point A represents a point of end diastolic volume of the left ventricle right prior to the beginning of left ventricular contraction. As ventricular systole begins, there is an isovolemic period, illustrated here in this vertical line up to point B, during which the ventricle is generating pressure, but the aortic valve has not yet opened. At point B, the left ventricle has generated enough pressure for the aortic valve to open, and the ejection phase begins, during which there is decrease in the LV volume as the blood is ejected into the aorta. And a point here designated in blue is reached where peak left ventricular systolic pressure is achieved, in this case, about 120 millimeters of mercury. At point C, left ventricular systole has ended and diastolic phase begins with a period of isovolemic relaxation, illustrated here by this vertical drop up to point D. And although the ventricular relaxation takes place, the pressure in the left ventricle is still higher than the left atrial pressure, and therefore no change in volume takes place. And as the pressure in the left ventricle reaches point D, the mitral valve is able to open, and the filling of the left ventricular cavity is able to take place up to point A, where it fills up to its end diastolic volume. The pressure volume loop is bounded by two lines. The first one is illustrated here in green, and it is the end systolic pressure volume relationship. And the second one is the blue line, which is the end diastolic pressure volume relationship. The end systolic pressure volume relationship is determined by the intrinsic contractility of the ventricle, whereas the end diastolic pressure volume relationship is determined by the diastolic properties of the ventricle. In this example, we could see that the slope of the end systolic pressure volume relationship is changing from the baseline, and it can either shift down and to the left, thereby increasing the contractility, or down and to the right with a decrease in contractility. And you'll see here, for example, that as the slope of the line in the low contractility example, the peak systolic pressure is only about 75 millimeters of mercury. However, as the contractility is able to increase and the slope of the contractility line goes up, the ventricle is able to generate a peak systolic pressure of about 125 millimeters of mercury. So for any given preload, afterload, intrinsic ventricular contractility and diastolic ventricular properties, the PV loop will have its own specific appearance. This is important because of the concept called pressure volume area, which is depicted in this graph here. This area includes the area inside the actual PV loop, which is designated by SW here, and the area before the actual PV loop, which is designated as PE, or potential energy. Taken together, the PV area is the main determinant of the myocardial oxygen demand, and that's why it's so important. And the ideal goal of treatment of patients with cardiogenic shock is not only to improve the patient's blood pressure, but also to decrease the myocardial oxygen demand. And this in turn can lead to a small degree of myocardial necrosis and lower risk of complications such as cardiac arrhythmia. In an ideal case scenario, what we're trying to achieve is to shift a given PV loop down and to the left, as I'll show soon. So in this example, we're starting with a baseline PV loop in the PV area. We're starting off with a borderline systolic blood pressure of around 80 millimeters of mercury and a very high left ventricular and diastolic pressure of 35 millimeters of mercury. And as we shift the PV loop down and to the left, we're able to reduce the overall PV area and thereby decrease the overall myocardial oxygen demand. But in this case, we can also see that there's an increase in the systolic blood pressure, which was initially 80 millimeters of mercury, which is now up to 100 millimeters of mercury. And we're also able to, by shifting the loop down its end diastolic pressure volume relationship down from 35 to around 8. As the curve is shifted even further down and to the left, the area under the curve reduces even further, and the myocardial oxygen demand is reduced that much more. But as you can see, doing so reduces the systolic blood pressure in the event, and in this case, down to 60 millimeters of mercury. And this would be dangerous level in somebody who does not have any further arterial perfusion. So this type of unloading and decrease in myocardial oxygen demand can only really be achieved with certain types of left ventricular unloading devices, such as an Impella device, which produces its own continuous flow, which maintains the systemic pressure, as I'll show you in later slides. On the other hand, anything that shifts the curve up and to the right will cause the opposite of what we want, which is a substantial increase in the PV area, and therefore an increase in myocardial oxygen demand. So in general, we don't want the curve to go up and to the right, we want it to go down and to the left. And here's another example of these changes all transposed onto one line. And once again, you can see that as the curve shifts down and to the left, we're decreasing the PV loop area and therefore decreasing the MBO2, which is the myocardial oxygen demand. And the opposite is happening here as we go up and to the right. So when we look at catecholamines, which were mentioned earlier in the talk, as being useful for acute improvement in hemodynamic parameters, you can also see that its net effect is to increase the total PV area as compared to the baseline curve, which is designated here in green, to a red curve here. And you can see that although the peak systolic systemic pressure will increase with catecholamines, the overall area under the PV curve is substantially higher. So initiation of catecholamines will increase the myocardial oxygen demand. So here's my poor daughter falling asleep after trying to understand the PV loops. And so now, for that reason, we're going to move on to the specific examples of our percutaneous support devices. In the interest of time, I will mostly focus on the actual hemodynamic outcomes of these devices, not so much on the data, although I'll present some of the data. So we'll start off by going over the intra-aortic balloon pump. And this is the earliest support device that was introduced back in 1968. The intra-aortic balloon pump, as can be seen here, is positioned into the descending aorta, and it inflates during ventricular diastole. This in turn will cause more blood to perfuse the coronary arteries during the diastolic phase and therefore increase the coronary artery perfusion. The pump then deflates during ventricular systole, and this creates a relative negative pressure system within the descending aorta, which helps to decrease the afterload for the left ventricular systole. In total, what this does is that it modestly increases the cardiac output and usually increases it to less than 1 liter per minute, but also has the effect of decreasing myocardial oxygen consumption. This device is usually placed through a femoral line, through a femoral artery, but can also be placed through an axillary approach. Here's a classic tracing of the aortic pressure, which is unassisted before the intra-aortic balloon pump is started and after the intra-aortic balloon is started. So as you can see, the usual monophasic aortic pressure tracing takes on a biphasic appearance due to the increase in the diastolic pressure during the balloon inflation and diastole. And as the balloon deflates, there is a decrease in the end diastolic pressure and therefore decrease in the afterload. And as you can see in this pressure volume loop, when we look at the baseline PV loop after initiation of the intra-aortic balloon pump, there is a curve shift down and to the left, which we again know that that will decrease the myocardial oxygen demand. So the main trial that evaluated the use of intra-aortic balloon pumps in the setting of cardiogenic shock in patients with acute MI was the IABP Shock 2 trial. The trial randomized 600 patients who presented with acute myocardial infarction and were planned to undergo earlier vascularization with either PCI or CABG to receive either intra-aortic balloon pump or no additional mechanical support. In a 30-day follow-up, the primary endpoint of all-cause mortality was actually similar between the two groups, as you can see here. Subsequent meta-analyses confirmed the finding of this randomized trial and really did not find any clear benefit to intra-aortic balloon pump placement among patients with acute myocardial infarction presenting with cardiogenic shock. And therefore, it's really because the positive hemodynamic effect of the balloon pump is very mild. And so it does not really result in substantial hemodynamic improvement that's really needed to affect the outcomes of these patients. And therefore, intra-aortic balloon pumps should really not be used as the primary support device in patients presenting with cardiogenic shock. A more recent comer to the scene of percutaneous support devices is the left-sided Impella device, which is a continuous axial flow pump, which is inserted in a retrograde fashion across the aortic valve into the left ventricle. And the motor on the Impella continuously aspirates blood from the left ventricular cavity and injects it into the ascending aorta. This is done independent of the intrinsic intrinsic left ventricular function. This is a much larger device compared to the balloon pump, and it generally requires up to a 14 French axis if common femoral axis is used, but will require a surgical cut down for a much larger placement, usually through an axillary. And these devices can generally provide anywhere from 2.5 liters per minute of flow to up to 5.5 liters of flow. Practically speaking, the percutaneous devices that are inserted in the cath lab are usually the CP device, which provides 3.7 liters of flow, and the surgical cut down that's required is used for the larger flow devices. So when we look at the change in the PV loop from baseline, which is depicted here in blue, to maximum Impella flow, which is depicted here in red, you will see that the curve shift down and to the left pretty substantially compared to what we saw with the balloon pump. And because the blood is being ejected continuously, irrespective of the cardiac cycle, there's also a loss of the isovolemic phases, the vertical ones seen here, and therefore the PV loop actually takes on a triangular shape. But because the PV loop is shifted down and to the left, there is a significant decrease in the myocardial oxygen demand with increasing support from Impella. The other interesting aspect is that as the left ventricle is unloaded, the peak left ventricular systolic pressure continues to drop, as seen here in the blue aortic LV tracing, excuse me. However, there's really no compromise despite that to the systemic perfusion, because you could see the pressure waveform, which is shown in orange here, actually increases from peak systolic of around 75 to up to around 140 millimeters of mercury. And this is due to the Impella's ability to independently generate continuous flow independent of left ventricular contraction, which really is uncoupled from the mean arterial pressure. So despite the robust hemodynamic support and LV unloading that can be achieved with Impella that I just showed you, compared to the balloon pump, currently the available data is very limited, and the randomized controlled trials are really largely missing. One of the most recent small trials that called the IMPRESS trial compared the outcomes of patients with cardiogenic shock and acute MI and randomized patients to intra-aortic balloon pump or Impella placement. And a total of 48 patients with ST segment elevation, MI, and cardiogenic shock were ultimately randomized in one-to-one fashion to either Impella or balloon pump. And the primary outcome or mortality was assessed at 30 days and 6 months follow-up, and there was no significant difference between either the balloon pump or the Impella. So the question is, why did the Impella perform so unimpressively compared to the balloon pump in this trial? And if you look at the possible explanations, it's really that the answer really lies in a clinical description of the enrolled patients. And as you can see, that the vast majority of these patients suffered a cardiac arrest, and you'll see that it was 100% of patients in the Impella arm and 83% of patients in the intra-aortic balloon pump arm. And these patients also had very high lactate levels upon presentation and low pH levels. So no matter what kind of mechanical support device intervention would be instituted in these patients, these are the sickest of the sick cardiogenic shock patients, and the mortality in these patients is going to be high no matter what you do. So really the question still remains, though, about the effect of Impella support among the more stable patients with cardiogenic shock, and can their outcomes be improved with Impella? So moving on to VA ECMO, which is another left ventricular support device, and with the caveat that really this device supports both the left and the right ventricle. And the circuit works by aspirating blood from the venous circulation, usually the common femoral vein, and then circulating blood back into the arterial circulation, usually through the common femoral artery. This can also be placed centrally, but most commonly placed through the peripheral femoral vein and femoral arteries. The system can generate up to 5 liters of flow per minute. And as we look at the PV loops, once again, you'll see that something very interesting is that unlike the intra-aortic balloon pump and the Impella device, which shift the PV loop down and to the left, in fact, when we look at the baseline PV loop here designated in blue, initiation of ECMO flow up to 4.5 liters will actually shift the loop up and to the right, which actually, as we already discussed, will increase the myocardial oxygen demand, not decrease it, as was true for the balloon pump and more so for the Impella. And the reason for this effect is that the ECMO-generated blood flow from the venous compartment into the arterial compartment will increase the total arterial blood volume in the arterial compartment, which will then increase the afterload. Since the left ventricle is not being directly unloaded by the ECMO, the increase in the afterload will force the left ventricle to work harder to overcome this increased afterload, and will therefore increase the myocardial oxygen demand. Despite this increase in the stress that's placed on the left ventricle, continuous ECMO flow does increase systemic pressure and improves the end organ perfusion. Now, due to the increase in myocardial oxygen demand on the left ventricle after VECMO initiation, some patients require additional decompression of their LV so that they do not they do not really decompensate further from the left ventricular standpoint, especially in patients who just suffered an acute MI. And this type of decompression can be achieved either through the surgical means, by ways of atrial septostomy or surgically placed LV vent, or percutaneously by placement of an additional Impella device. Now, specific consideration for mechanical support using VA ECMO system is the concept of a mixing zone. And that concept is that since the arterial blood in the ECMO circuit is being injected into the arterial circulation in the retrograde direction to the native LV contraction, there's going to be a resistance to this retrograde ECMO flow if the left ventricular ejection is significant. So in panel A here, you will see an example of a patient with a severely impaired left ventricular flow, and therefore the native stroke volume is very minimal, and therefore the retrograde flow from the ECMO will be successful in reaching up to the ascending aorta and will therefore perfuse all of the branch vessels, including the cerebral vessels on both sides. However, as the LV contractility starts to improve and the stroke volume increases, there's going to be a mixing zone further away from the aortic valve, and in this case, for example, in the ascending aorta. Still, the retrograde flow through the ECMO cannula will still be able to perfuse the arch vessels, and there will be no compromise in oxygenation. However, as the LV function really starts to improve, as seen in panel C, the mixing zone will shift down and potentially shift down into the descending aorta. And if the left ventricle is ejecting blood that's deoxygenated, for example, in the setting of severe lung injury, this relatively deoxygenated blood will preferentially perfuse the arch vessels and can really cause hypoxia to those vessels. And so in these cases, a VA ECMO configuration should be changed to a VAV configuration, which can improve oxygenation to the branch vessels. So as with all mechanical support devices, the available data on ECMO is limited. And in a non-randomized study of 138 patients in the study by Mueller and colleagues, all of these patients had acute MI and cardiogenic shock. The survival to discharge was 47%, and overall survival at 1 year was 38%. On the other hand, the rate of ECMO-associated complications was pretty high at 39%. Now, one very helpful use of ECMO is among patients that are undergoing active CPR, the so-called eCPR, where the ECMO is placed during active ACLS. And the data on this, again, is very limited, but from what's available, the patient survival has been described up to 30% of all cases among patients who are presenting with acute MI and would otherwise not have survived. So my daughter here realized that actually the heart has more than one ventricle. And so let's finish off with reviewing the right ventricular support devices. So we will go over the tandem heart cannula and the Impella RP. So starting off with the Impella RP, which is a 22 French, so a fairly large device, axial flow pump, which is mounted with an 11 French catheter. This catheter is inserted through a common femoral vein and is passed into the pulmonary artery. And the blood is aspirated from the right atrium and then re-injected into the pulmonary artery, therefore bypassing the right ventricle altogether. And this type of support can produce up to 4 liters a minute of support. The use of Impella RP was evaluated in the RECOVER Right trial. And in this trial, 30 patients with RV failure, which was refractory to medical therapy, was evaluated. This was a non-randomized trial. The patients with RV failure experienced issues with the right ventricular function either after left ventricular assist device placement or after acute MI or cardiotomy. And at baseline, these patients were on multiple inotropes and pressors. The primary endpoint of the study was 30-day mortality, and the safety profile was also evaluated. And following device placement, interestingly, there was a significant observed increase in the cardiac index in the majority of patients, and in decrease in concomitant CVP in the majority of patients, which are all the beneficial effects that we expect to see in patients who are initiated on RV support. Following pump implantation, patients were also able to decrease the amount of inotropes that were required to support their hemodynamics. And the primary endpoint of survival to discharge in the overall study population was around 73%. All patients who were discharged were alive at 180 days, but what was important is that a majority of these patients did develop bleeding complications, and 13% of these patients did have hemolysis. However, due to the high survival rate of these patients, which were otherwise extremely sick, this led to the FDA exemption approval of this device for RV failure patients following LVAD implementation, acute MI heart transplant or cardiotomy. And finally, to finish off with the Tandem Heart, which is the second device that we can use for patients with right ventricular failure for percutaneous support. This is a larger device, which requires a 29 French dual lumen cannula, which is inserted through the right IJ approach rather than the femoral approach. And the blood similarly is aspirated from the right atrium and is then re-injected into the pulmonary artery, bypassing the RV, also giving you about 4 liters a minute of flow. And one additional benefit is that this device comes with an option for an oxygenator, which can be very useful, unlike the Impella RP. And the use of this device was evaluated in 2013 trial by Naveen Kapoor. It was a retrospective study of 22 patients that were cannulated percutaneously. And in these patients, again, there was a decrease in the right atrial pressure and an increase in the cardiac index. And so it is also a good option for patients with RV failure. All right, and thank you very much for your time and your attention.